Good afternoon, everyone. This is Danny Davis with DMS. The time is now 1:58, and we are still clearing the waiting room. And we are also waiting to see if Dr. Schuster is able to join. So we'll probably give it another moment.
Good afternoon, Danny.
Good afternoon. How are you?
I'm good. How about you?
I'm doing well.
Good.
As of now, I just see yourself, Mr. Shannon, and Miss Mudd here for attendance.
Okay, thank you. I think our new member is going to be able to join us at the beginning of the meeting, hopefully.
Okay. I will keep an eye out.
Yeah, that would be great. Thank you.
Hi, Danny. This is Dr. Terrio. I noticed that an AI assistant is on recording or taking notes or whatever, and I don't think those are allowed.
They are not. So what we're going to do is put read stop in the chat box, and I think that should take care of it. But yes, just for everyone
Thank you.
joining, AI notes and everything AI related is not permitted during these meetings.
Is that true of all the open meetings, open records?
This is Christy Armstrong. That is actually not an AI. I believe that that is information age. That is a location of the computer that is being used.
Oh,
I am.
Oh yes,
Oh,
as
it's
the participant that joined with the IA.
Yes, that's information age, and that is a computer that is there. That it the information age station number 2. It is not it's not an AI in any way.
oh, okay. Learn something new every day. Thank you.
I guess I'm showing off my dyslexia.
Danny, this is Leslie. One more thing. I'm not able to put anything in the chat. Do we have a function that's keeping me from doing that today?
There should not be a function active that would prevent you from
Yeah, it's not letting me.
participating.
I've tried cut, copy, and paste, snip. I'm trying to copy. I can't. It's not letting me. It won't let me paste it to the chat. Okay.
I'm going to send you an individual message. Let me know if that works. And if that doesn't, try leaving and then rejoining the meeting.
Got your message. Let me see.
Okay.
Let me just see if it'll let me put it in yours. No, it won't let me put anything. It'll let me type, but it won't let me paste anything in.
If there's something that you'd like to paste, would it be okay if you sent it to me and I could paste?
Yeah, I can send it. It's it'll be a little bit down on the list, so I'll go ahead and send that to you here in just a little while, and you can send it out to Dr. Schuster and team, or you can put it in the chat too.
All right, that sounds good.
Is there any way to fix that though, Danny? Because people put stuff in the chat all through our meeting.
It might just be me. Danny, can you try? Can you just grab something and see? Here,
I'll try to send something, Leslie. I'll try to put something in the chat.
Thank you. Thank you.
I can write, but I can't paste anything in.
So it
And
seems,
mine went.
yes, it's coming through.
Yeah.
Leslie, it's just you.
Well, I can type, but I can't cut and paste, and that's what, so I can type, but I can't cut and paste anything into it like normal.
We
So
have your last message just went through when you sent Leslie in the.
yeah, but
in
it
the
won't
chat.
let me cut, it won't let me copy or paste anything.
Okay. Sorry about that. I'm not too
Okay,
familiar
that's
with that
okay.
function, what would prevent that, but I can certainly look into it.
No problem. I am going to.
Yeah, and our newest member has joined us, Danny, and I think probably, I think Melissa Algeier is on for PAR. Are you,
Okay.
Melissa?
Yes, I'm here. Sorry, I'm trying to
Okay,
eat.
that's all right. So we have a quorum and we've got a busy agenda. I think we ought to go on and get started. And we have 120 people on the Zoom, so I always say you can't pitch a tent big enough for behavioral health, so that's a good. So welcome everyone to the behavioral health TAC meeting. I just saw someplace where we've had 60 meetings, which is 10 years worth of these BH TAC meetings. I guess that's right. I guess it was the 2016 session when we established the TAC. Anyway, welcome to you all. As they say on the airplane, if you're on the BH TAC, you're on the right flight, but otherwise, we'll see you later. And let me ask our voting members to introduce themselves. And I'm going to do the first introduction because I'm very pleased that we have a new voting member of our TAC. We've been short, as you know, from the brain injury community. So we have Dr. Greg Perry, who is a friend of mine, is a neuropsychologist, and he was appointed by the Brain Injury Alliance of Kentucky, and he's replacing Misty Agnew, who had a scheduling conflict. So, Greg, you want to say hello to folks?
Sure. Good afternoon, everyone, and I'm happy to be part of this meeting. I know a little bit about the behavioral health TAC from Misty and having talked to Sheila, so I'm looking forward to participating.
Yeah, we're glad to have you, Greg. Thank you. Val, you want to introduce yourself, please?
My name is Valerie Mudd. I've been on the TAC for as long as I can remember.
Yeah, I think from the beginning.
Probably. I represent NAMI Lexington and Participation Station, which is a peer-run, peer-operated center, and I represent the consumer voice, people living with mental illness like myself.
Thank you very much, and we're always glad to have you, Val. Steve?
Yeah, Steve Shannon, I'm with CARP, Association of Mental Health Centers, and I represent the mental health centers. Glad to be here.
Glad to have you, Steve. And Steve's been with us from the very beginning as well. And then PAR, People Advocating Recovery, and I think it's Melissa today.
It is Melissa. This is Melissa Algeier, the program manager at People Advocating Recovery, representing the recovery community and substance use disorder.
Great.
Welcome, Greg.
Thank you. And is TJ Lidovic on? Have you seen him, Danny, come in?
I do not believe he has come up yet.
Okay. I'll have to check with him because he missed our last meeting as well.
Yeah.
All right. So we have a quorum. We have long-winded minutes from our May 14th meeting, which is, as many of you remember, was full of discussion and went overtime. So hence the long-winded minutes that I prepared. Do I have a motion from one of the voting members to approve the minutes of our May 14th meeting?
Steve Shannon, so moved.
Okay, and a second, please.
Second, Val.
All right, great. Did you all see anything that needed to be corrected, omitted, added? If not, I'll ask for a vote. All those in favor of approving the minutes signify by saying aye.
Aye.
And those opposed, like sign, and abstentions. And thank you very much. I have on here, the next item would be the response from Medicaid to the recommendations. We had 3 recommendations at the June MAC meeting, Medicaid Advisory Council meeting. But Danny reminded me that DMS has 45 days after the MAC meeting to respond to the recommendations. So our timing is just off. They're not due until July 17th, and we're having our meeting now. So we will have to bring those up at the next meeting. You may remember that the one recommendation was a second time around on whether all of the prior auths that had been approved by DMS for well care had actually been rescinded, and we will get to that because we have another item on the agenda for that. We also recommended that the MCOs be required to notify providers about implementing any changes that affect provision of services. And the third was that the MCOs be required to make any new prior authorizations available to providers. So we're just trying to make sure that we all have the same information and we're all operating with the same information. So we will put those on the agenda for the September meeting. I hate to think that we're already talking about being past the summer. We have on here a repeated item, and it has to do with the claims payments for newly certified CCBHCs, Certified Community Behavioral Health Centers. And I understand, Steve, from what you said, that when you've had your monthly calls with the MCOs, that you have not been encountering any problems.
There's always problems, but they're much fewer. So we had a call, actually had 2 this week, and no one raised real concerns about this issue right now.
Okay.
I like to keep it on just in case.
Oh, okay. I was going to ask you that. So we will keep it on. Thank you very much. The next is, I think, going to be a lengthy discussion with Commissioner Lee and whoever else she wants to respond. And that has to do with questions around the letter sent out from DMS dated June 8th, although I think most people got it about 10 days after that, talking about cuts that would begin on August 1st or sometime shortly after that, a 4% cut in Medicaid provider reimbursement rates. And are you going to be answering those things, Commissioner Lee, or?
Yes, yes, Dr. Schuster. I do not have my CFO on here with me, but I will answer every question that I can for you all.
Okay, thank you. We will publish, we had sent 4 questions way prior to this meeting. In fact, maybe right after the letter came out, and Commissioner Lee was very kind and posted responses to those, and they had to do with just clarifying that the reimbursement reductions will be applied to the fee schedule that was in place as of June 18th, 2026. That the reductions will apply broadly to the provider types identified in the notice, because we had asked whether all codes that were billed, and I think the answer is that you're doing the rate reductions, Commissioner, by provider type and not by codes. Would that be correct?
That's correct, Dr. Schuster. And I think before we get, on into a lot of the more detailed questions, I'd like to, just say that, this is not something that we take lightly. As you all know, that there's a lot of scrutiny on the Medicaid program and the growth in the Medicaid program, not only at the state level, but at a national level. And this is an issue that's not just impacting Kentucky, but what I really want to point your attention to in the letter is right immediately after that August 1st date, there's a few words that says or first administratively feasible date. Now, what that means is that when we go to start implementing these changes, we still, Dr. Schuster, as you had in your questions, we have to do a state plan amendment. We have to get some approvals from CMS. We have to do some regulations, and that is taking some time, and we have to make a system change. We also had in that letter that additional information will be forthcoming as far as impacts. So what I want you all to know is, we're coming up on that August 1st date. We're just a month out. We still have some work to do. We don't anticipate changes being made by August 1st. And if and when we get those changes made, we will definitely give a 30-day notice, at least a 30-day notice before they're implemented. So what I'm saying is, I know that how important the work you do is. I know how scary change is. I know how uncertainty makes it difficult for you all to operate. So I want you to just kind of take a breath with me right now and know that when August 1st comes, we don't anticipate that 4% cut being made. And again, lots of stuff that needs to happen, and we're going to communicate. And what we need to do, and I know y'all heard the budget talk, and 2027 is going to be difficult with their budget, and 28 is even a little going to be more difficult. So we're going to have to start planning for 28 too. But for right now, again, first administratively feasible date, and additional information will be forthcoming when we know exactly when we can make those changes. And the other news, I think good news for providers, is that those changes will not be made retroactive. Even though that August 1st date is in that letter, for example, if we can't get those changes into the system until September, October, whatever, we're going to go forward. We're not going to go back to the August 1st date to make those changes.
Well, that's good news, and I appreciate that.
I'm glad I could give a little bit of good news in some of these bleak times.
Yeah, so they will not be retroactive, no matter when they actually go into effect.
Correct. Not correct. And we will give advance notice. Again, we knew that was, a little bit of an aggressive date, and weren't sure everything we had to do. Well, we knew what we had to do, but it's just taken a little bit longer because, as you all know, currently what we're doing, we are in the midst of making major programmatic changes for the work engagement, work requirements, and community engagement. We had to send a notice out yesterday, or was it this month? We had to send a notice to all Medicaid expansion members. And we have the same team of people that's working on that community engagement, that's got to work on our rate reductions and work on our fee schedules. So it's actually, those changes in HR1 have taken up a lot of bandwidth, and we can't move as quickly as we used to be able to.
Yeah, you all have you have the MOAB to report to and participate on, which is, in its just beginning its second year, but you have lots of pieces that were not in requirements before. So we had verified with you in those earlier questions that the regs would have to be changed and the state plan amendment would have to be changed.
And what we're looking at with the regulation is we're looking to see if we can do one regulation that states that in the event that we have to make quick changes, or can't meet can't stay within our allocated budget, that we can make those changes. What we would really like to do is do one regulation that stands, so we don't have to do a regulation every time, because the state plan amendments will take a little bit more time. But we're just trying to get ready for that. If and when in the future we experience these same issues, we want to be able to act as quickly as we can. So that there's that one regulation, and the state plan amendment, it's out for public comment right now. So I think, let me double check. I'll have to double check and make sure, because we have been talking to CMS about it. And if it has not been posted, we'll be posting it very soon, and that will be public comment.
All right, please let us know, because I have not heard that it's out.
Yeah, we're probably working. We're probably working on that.
Okay, and will you send notices to all the TACs and the MAC and
Yeah.
the BAC.
Yes, when we
That's
get that
the
out.
case. Okay,
Yes, yes,
thank
we
you.
will.
Yeah. Let me ask you, because I know that the other thing that you're required to do, I guess, in the budget bill, maybe, or maybe in HR.
House Bill 2,
House Bill 2, yeah.
or House Bill 695. I get them confused. House Bill
Yeah.
695.
Or House Bill
695.
500, maybe it's actually in the budget bill, that you needed to report to the Appropriations and Revenue Committee. And I think you did that
Mhm.
just last week, 2 weeks ago.
Yes, we gave them notices when we sent the letter out.
Okay, I've had some eagle-eyed person emailed me and said the list of providers that's in the letter that you all sent, Commissioner, is different than the list that you provided to A&R.
I think the only difference, if it's different, the only difference would be there was a word left out of the letter, the list of providers that went out to the providers should have had the word potentially impacted providers.
Yeah, I'm talking about the actual list of the impacted providers.
I'll have to double check that.
Yeah, well, one major one that was brought to my attention is that the BHSOs are not listed in the list that went to A&R.
Huh. I'll follow up with that one,
And
Dr. Schuster.
Yes, if you would, somebody needs to, and they're not in the same order, so it makes it a little bit tricky.
Yeah.
I have not done the crosswalk, but you might want to have somebody.
Yeah, we'll double check that one.
Double check. I assume, well, let me ask you, which is the actual list of providers, the one that went out in your?
I would stick with the one that went out in the letter and two that should have had potentially impacted providers up there.
Okay. But that one also lists the provider type numbers, so that's helpful for people.
O3's on there, Dr. Schuster.
Yeah.
Yeah, that one is on there.
Well, you may want to issue
we'll follow up with A&R.
Updated one to A&R, but I did want to ask you about that. Thank you. So your timeline, I think you're talking about, you're going to have to actually wait until the state plan amendment and everything aligns at whatever date that occurs.
Yes, that's what we will do. Now, when we submit a state plan amendment, you know that it has to be submitted within the quarter in which you want it to be active. So but we're going to make sure we line everything up. So for example, if we got the state plan amendment in July, let's say, or August, it could be effective 7/1. But as I said, we are not going to go back. We will make sure that it goes forward. It's not going to be retroactive.
Okay.
And we will align all of that up.
Okay. And will all of the provider types be affected at the same time?
We're not sure about that. Because of system changes and things that we have to do. And again, working on community engagement or work requirements. I think we need to start calling it what it is. It's work requirements. And working on that. We're not sure if we could get everybody, at one time, or if we may have to do some sort of tiering structure. So.
Okay. So that's something that providers will really need to keep an eye on.
Yes. And again, just, getting that message out there. I know that August 1st date was in there, but with us having to do the community engagement and the system changes, it's a little bit of a heavy lift for us to try to get all of that done at once. And so, again, just making sure that we get this word out there to our provider community that please pay attention to that or first administratively feasible date and the language that says additional information will be forthcoming. So again, we'll give at least a 30-day notice before those changes take effect. We know that providers have to plan. We know that this uncertainty is definitely a scary time for them. And we want to be here to support as much as we can because the provider community, my motto is that the Medicaid program was created for the Medicaid member, but we can't take care of our members without our providers, and we're here to support in any way that we can.
Well, we certainly appreciate that. So in the chat, just to verify, the list of providers in the letter should all be considered potentially impacted providers.
That is correct.
Okay. And then the other question is, and I should know this because I'm on the MOAB, and we did have discussion about, does the MOAB have to approve state plan amendments?
Yeah, no, the MOAB does not have to approve state plan amendments, but per 695, we have to send all state plan amendments over to the legislative body, and I would think that the legislative body would send them down to the MOAB. We'll have to go back and revisit that language in 695, but we have to.
They have to be submitted at least.
Yes.
There was legislation, right, that Senator Gibbons filed?
That said, pardon me, I didn't hear that last part.
I think there was legislation that Senator Gibbons filed, but I'm not sure that it passed.
Well, I know 695 says that we can't make any changes to eligibility or benefits, but it does not include reimbursement. Before we have to get approval for benefits and for any changes in benefits and eligibility, but reimbursement was not included in 695 in that requirement.
Okay. All right, thank you. And then you mentioned when you replied to our earlier questions that you all are compiling a FAQ that will be posted online. Do you have any kind of timetable for that?
I don't. I mean, these 4 questions and a couple that have come by email are mainly the ones that we have received, but I think it's really important to get something out there before the August 1st deadline, because I think, that we definitely need the providers to know that, number one, it's not going to be retroactive, and number 2, that we'll give additional notice before we make those changes to those potentially impacted providers.
Right. So one of the questions that we have that were also sent over to you ahead of this meeting, this is like a second set. The first one is, what criteria was used to determine which provider types or codes would receive cuts?
And I'm sorry, I didn't see those questions, but I can tell you that we looked at every provider type, and we have some, for example, you'll see that are not on there, such as FQHCs or rural healthcare centers. And that's because those providers are cost-based, and we have to cost settle with them anyway. So it wouldn't be, prudent, or wouldn't be feasible to change our system to reduce those rates and then have to give them, the money at the end. And the FQs and the RHCs are a little bit different. So any provider that is cost-based could not have been considered in that
That would include the CMHCs, since we're in the behavioral health.
30 and 16 excluded, Dr. Schuster.
Yes.
That's CMHC and CCBHC.
Yeah. CCBHCs and CMHCs. What are the projected cost savings from these cuts, Commissioner?
I'd have to go back and look at that and see what we have anticipated, but I do know that the anticipated cost savings are still not as much as what our budget deficit was projected to be, but I'll have to go back and get those specific numbers.
Can you follow up with me on that? Because I think that's a question that people will want to know. I think there's been lots of back and forth between the administration and the legislature about how good or bad the budget is and so forth. So it would be really, really helpful to get that estimate from you all in terms of what you're seeing as the budget deficit for 2027, let's say, and what you think that the cost savings would be from these cuts.
And I do know that our CFO does have that information, and I'll get that and follow up with you, or follow up with Danny, and she can get it out to.
Yeah. Okay. Another question in the chat: where do we go to find online where the notices will be posted? I assume that the notice to the providers that the 30-day period has started you send those actually out directly to the providers, right? By email?
We did too. And that's why that date of June 8 and June 18, while there was a little bit of a disconnect in those dates, because that letter had to be processed, and there was the mailing and the process took a little bit of time, but we sent that letter out in two different formats. We sent it electronically through our provider portal, and then we mailed the hard copy also to providers. So the letter is posted though online. The letter itself with the provider types is posted online in their link. I'll see if I can pull that up and put it in here. We have a provider link on the FAQs. Those will be posted online too. We'll send a link out for when those will be posted, or when they'll be posted.
Okay, but it'll be on your DMS website someplace.
It will be.
Yeah, helpful to have the link. One of our questions always in behavioral health, and this comes up, as you know, Commissioner, you and I talked about this a lot. Our motto is get people in early and take care of things before they get much worse. So I guess part of the concern that we have is that there may very well be fewer providers and fewer services offered. And they may very well be some of those early intervention kinds of services, which leaves people not getting what they need and then developing services that require higher costs. So I guess the question is, as you're looking at, and I'm going to talk about behavioral health because that's what we're here for, looking at behavioral health providers across the board, did that figure into your calculations about what your savings were going to be, what the impact was going to be actually in terms of the kinds of services that were going to be utilized?
Yeah, I think that's a really good question. I don't know that that's something that we can anticipate how providers may change their business model. But the one thing that we definitely want to focus on is access to care and make sure that our members are receiving access to care. And it's going to be very important for our providers, our communities to alert us to any individual who's having a difficult time accessing care so that we can intervene and make sure that they get the services that they need. But again, that's a really good question, but just very difficult to determine if and how providers may change their business model.
Yeah, I think we're all concerned about the Medicaid members getting what they need. And so, the anticipation, in fact, our next question is, how will the impact on access to services or what will happen in terms of tracking changes to provider availability?
So we can definitely track the enrolled providers, for example. That's one thing that we're going to keep looking at in it. And this is not just for this exercise, but just going forward. We need to track our provider enrollment, not only by behavioral health, but by every provider type, to see why providers are leaving, or how many are entering the market, or where we see some gaps in care. And we can track that by county. We can track that by, I think we need to look at the providers and the number of Medicaid members versus the number of individuals in that county in general, to make sure that we have enough workforce to cover the needs. So that's something that we can definitely track. And Dr. Schuster, if it's something that you all would like to see on a routine basis, if you would like to see, because we have been tracking, I've been looking at some behavioral health provider enrollment. And if you all would like to see a report based on provider enrollment by type, by county, if that's something that you think this TAC would be very interested in seeing, we can, just make sure that you let us know what sort of report is related to providers that you want to see, and we'll get that for you all to review.
I think that would be great. And I think it would be great to have it at our next meeting, because it would be kind of a baseline, Commissioner, assuming that if the cuts may not have started maybe by September, but if they have, they will just have started. So it'd be really good to get that baseline number if we can request that of you.
Yeah, so we have some of that information. Again, I've been monitoring. It's not at county level. So if you can kind of think, Dr. Schuster, maybe talk with some of your other TAC members, exactly what you would like to see, such as, behavioral health provider type by number enrolled by county or whatever you want to see in there. If you can get that to Danny, I know there's a formal, recommendation and process like that, but this is a data request. If you get that to Danny, she'll review it and get it to me, and we'll make sure we get it, because I think that's a big piece of what the TAC can do is, look at those that sorts of data points. And so this will be a good one to look at as we move forward, not only for now, but in 28, if there's, we anticipate a budget shortfall in 28, what does that look like? What happens? Where are we really concerned? And so any sort of data points that you all think that you need to help, and Dr. Schuster, it just, you being on the Moab and stuff too, any sort of data points that you think that we need to monitor and look at here that you could, may help take to other venues,
Yeah.
and you're chair of the TAC of the MAC. So
yeah. Well, let me go back to the consumers then, the Medicaid members. I think this would be a good time. I don't know how you have your data in terms of utilization. But again, if there's some kinds of, and maybe we can ask, more specifically in a data request to at least get some kind of baseline numbers on utilization of various behavioral health services by county, again, before these cuts go into effect. I think that would be really, really helpful.
I think
Yeah, I
that would
agree,
be
Sheila, because there could be a migration away from some services that people really need.
Yeah.
And I think that that's going to be really important to develop some of those reports that are going to help you all see what's going on in the behavioral health healthcare landscape. And it may be y'all may be able to pinpoint, well, here's a gap in care, or here's something that we need to look at, or and just kind of, I think that these first two with providers and members, I think that's going to give you a really good baseline, like you said, Dr. Schuster, and then thinking of anything else that you all could look at to help drive policy, and I'm not talking about, Medicaid reimbursement. I'm not talking about, oh, give us money here, and if this code was this or whatever. It's just actual policy of what you're not seeing or what you are seeing in the healthcare landscape as it relates to Medicaid.
Yeah. And it also is going to make an impact, I assume, on the MCOs in terms of their network adequacy.
Yeah, and because
we've raised those questions in the past about, if every behavioral health provider is considered exactly the same as any other one, which is not the case, but the way they're classified.
Yeah.
But I think, and Mandy, also waitlist data would be really, really important.
Yeah, and with waitlist data, I know that's for the waivers. We can, and with the TAC, you all are our eyes and ears out in the community. So when you all hear of individuals who maybe can't get in to get care, let us know so we can definitely intervene on those cases to make sure that the MCOs are fulfilling their part of the agreement, and that we know where there are gaps in care so we can think about that.
Yeah. All right. Well,
Sheila, can I ask a question?
Sure.
Please. Yeah. The MCO piece came up the last couple of comments. How does the August 1 letter impact the MCOs?
That's a great question, Steve. This is this is going to be our fee for service fee schedule, and we do know it's going to have some impact with the MCOs and providers, especially if they have a contract with a provider that says they pay the fee for service fee schedule, or they pay a percentage of that fee for service fee schedule. So that's how it would impact the MCOs and payments, and that's the other thing that the providers need to be aware of, is what exactly does their language in their MCO contract say, and would they be, how would they see that impact too?
Well, currently MCOs are sending you a letter saying that they're sending an amendment to your original contract, now wanting to do a percentage versus the fee for service. So how do we manage that?
So the MCOs are sending you a letter saying they want to amend your contract?
Yep. We have Humana, who is currently reducing our contract to 80% of the fee for service or the Medicaid fee for service fee schedule, effective it'll be 9/1 roughly. And we are trying to meet with them and negotiate that, but we've not had any luck thus far. But yeah, they're amending, they're doing they're calling it a unilateral amendment, and stating that they're only going to pay 80% of the Medicaid fee schedule. And that's in addition to already the 4% reduction we're getting.
Thank you. Thank you for bringing that up and making me aware of that so I can follow up. I'm sorry I don't have a good answer for you today, but let me follow up and see what we can do with that one.
You do have an email from me, Lisa
Okay.
Lee,
I'm sorry.
that you responded to.
Oh, did I? Okay, I'm
Yes.
sorry. Did you have that? Okay, I'm sorry. I've gotten a lot of emails
I
over
bet-
this.
I'm sure.
bet you
so-
have.
Sure.
Yeah.
So,
Yeah.
so let
Yeah.
me, I'll go back and follow up again. But thank you for bringing that to this forum too.
Thank you.
If you don't mind, Commissioner Lee, I think, there's a lot of curiosity around this, and in the spirit of transparency, I just want to make sure this group is also aware that the state fee schedule also influences the capitation payments to the MCOs. So the way that process works is the encounters or the utilization, the visits that come through for each MCO, the actuaries take a look at that. It's not what we paid, it's what the service is multiplied by the state's fee schedule. And that sets the cost basis for the program as a whole, which then sets that monthly capitation fee. So there is a direct correlation to state fee schedules, and then downstream the MCO payments, just like there is to providers. So I just wanted to make sure everybody was aware of that.
Thank you for that input, Krista.
Yeah, I'm going to go back. Lucy, you just spoke up. Did you say you're already getting a 4% reduction?
Well, no, we were in anticipation of the additional 4%
Okay.
potential. But right now, the letter we received on the 4% did include BHSO. So we're anticipating the 4% cut. But then on top of that, yes, we got notification that we were also going to get a 20% reduction for our Humana clients or patients.
Okay, thank you. I just wanted to clarify that.
And we're with Isaiah House at that. Just so
Okay,
you're
thank you. Yeah,
Yeah, thank you, Lucy. I remember your email now.
yeah. So a question in the chat, Commissioner, are all services provided by the potentially impacted providers affected? I think people are still wondering. The example here is the ACT services provided by an LCSW.
So, yeah, that's the current plan is all services on a fee schedule would be impacted. So, I mean, is there a question or a thought process that maybe that the 4% wouldn't apply to all services on a fee schedule?
I don't know. Kathy, you want to respond to that?
Yeah, no, I was just just thinking it through, honestly. It's got the potentially impacted providers, and I guess I wasn't really thinking, and I was trying to think how that correlates to the services that are being provided. So I guess you've answered my question, though, Commissioner.
Thanks, Kathy.
Sadly, I think you've answered my question.
Yeah.
Yeah. Okay.
Sheila,
Well,
Michelle Sanborn has her hand raised.
Oh, I'm sorry. I can't see hands. So Michelle?
No problem. I just wanted to follow up with what Krista was mentioning about how this impacts the MCOs.
So I can hear you.
if
I'm on mute in this meeting, so they can.
If the fee schedule is cut and then rates go down to providers, then that number is used to calculate the per diem, I guess, for the MCOs. When does that occur? Does that occur every month? Does that occur like every 6 months? Or, I mean,
I'll have to bring my CFO into that conversation. I don't think I can answer that question with expertise as he could. And I don't think that he is on the call today. So we will follow up with
yeah,
that
so just
question.
trying to
How-
understand
but
how this impacts them as well, so that when we're advocating, we can say this impacts us, then it impacts them. I mean, the trickle down. So I'm just trying to
Right.
understand the trickle
Yeah.
down.
Yeah. And to be honest, we already took a 1% rate cut effective 7/1 for the MCOs. So on our capitation rates, it happens every 6 months. So, this should be a moment where we're all coming together to see how we can optimize what we can to continue to serve members, because there are real challenges with the state budget. I'm only stating the MCO component of it because I don't want anyone to think that like this is just the budget cuts are only directed at the providers in the system. I think DMS is doing the best they can to make the whole policy around the Medicaid program work as well as it can, but while hitting the very real budget constraints we're seeing with pulling back of dollars from both the feds and the state budget.
Yeah, no, thanks, Krista, because I think my thought was this is being cut by the providers, but then that money was really going to be kind of a savings for the MCO. So
No.
but so that your rate gets cut as well.
Correct. Yes.
Yeah. I think
Thanks for telling us that. I appreciate that.
and that goes back to what Krista was talking about a few minutes ago. Their rates are in their contracts with providers, and those are proprietary. And we really don't know. And there could be cases where some MCOs pay providers maybe more than the fee schedule based on a variety of factors, including quality of performance or that sort of thing. But when the rates are developed for the MCOs, it's based on the fee schedule that we have. So that's what Krista was alluding to a few minutes ago, that even though when we reduce these rates, it will result in an eventual capitation payment rate decrease, which will impact their ability to continue to deliver services with the capitation amount that they have. Did I say that right, Krista?
Yeah, exactly.
I think
I just wanted to make sure this wasn't like people aren't thinking like MCOs are lining their pockets with cash while providers are taking a cut. We all collectively are taking the cut to try to hit the budget.
Yeah. So Krista, you said you all took a 1% reduction July 1. Is that a 1% reduction in your per member per month?
Correct.
Their capitation payment. And there's a variety of factors that go in there. And we do, as Krista said, there's about 6 months, we'll look, but we can look. Our actuarial firm does monitor the MCO spend routinely, and we can make adjustments outside of the normal time that they're scheduled to be made.
So this really,
sorry, Sheila. Was the 1% reduction to the MCOs a function of the budget or a function of actual spend?
It was a function of the actuarial analysis that was done on the claims that were in the system at the time. So it was not related to the budget. And for example, I mean, Steve, that's another good question. For example, I think House Bill 2 says that we have to reduce the MCO capitation payment by 2 or 2.5% or something. That's not the way capitation payments work, and federal law will not allow us to just arbitrarily reduce their payment rates. But this, as we go forward, we're just going to have to monitor the spend, monitor how we do, because the discussion today has shown that the MCOs will receive a reduction in payment. And it's getting, the Medicaid program, as important and as vital as it is, the concern, I think, with legislators and others is the program continues to grow, but a lot of that growth is due to some of the legislative actions that have been put into the budget. We know, for example, in this current budget that there are some very specific. For example, the dental community, it will be receiving some increases. There's another amount allocated for a K-care program. There's another one for ventilator dependent hospitals. Those kinds of costs that are in the budget bill that we're going to have to do, and it's not anything that we disagree with, but that's putting additional costs in the Medicaid program that we're going to have to fund going forward. So again, not that we disagree with anything, but we don't make any of these decisions lightly, and we don't want to cut any Medicaid provider reimbursement because we know how vital they are to serving our population, and we just it's not something that we want to do because we know that it's gonna end up changing the healthcare landscape.
Yeah. So our next question, actually, this is a good lead in because our question was, will there be a corresponding per member per month cut to the MCOs like the providers are getting? Will this reduction mirror the 4% cut to providers?
I don't know that it's going to exactly mirror it. I mean, it could end up in a higher reduction for the Medicaid MCOs, or it could be, there will be a reduction. And like Krista has pointed out, the MCOs are not going to be, they're going to be impacted by this also.
Dr. Schuster, this is Justin Derringer. When they do those rate studies, that actuarial analysis, one of the main things they look at are our fee schedules. They look at the prices we have for each code. They calculate how many times those codes were paid per member, per MCO, and that's a big part of how they calculate those capitation payments they pay the MCOs. So when we reduce our rates, it reduces their capitation payment immediately. And our actuaries monitor the medical loss ratio to those MCOs closely. And so that's, all those things are heavily monitored. I know there's always the thought of, if we cut our rates to the MCOs, get that money, but they don't. They see the same cuts that happen in real time that our providers will see. So.
Yeah, it's helpful to understand that a little bit better, Justin, and this has been a good discussion.
There's a question very
Yeah,
similar,
I'm
very
sorry.
similar. Oh, in the from Karen's iPhone, if MCOs are wanting to cut providers 80% of the rate, Medicaid is cut by 4%. Wouldn't that be a windfall for the MCOs? And I think based on the discussion we had, it's a very complex. The Medicaid program is extremely complex, and reimbursement rates are different for different providers. And so I don't think that we can say that the MCOs would be getting a windfall. And two, the MCOs do have a 90% medical loss ratio, which means they have to spend at least 90% of their funds that we give them on those capitation payments on direct services. If they do not, then they return that funding to the state. In addition, we have a 2.5% or a 2% withhold that the MCOs, we keep that money, the 2%. So we keep that, and the MCOs earn that back through certain value-based arrangements, quality measures, that sort of thing. So that's 92%. So they're operate, and they have value-based, or they have value-added benefits that Medicaid can't provide. So they're already operating at that 92% threshold. They have that 8% threshold for other administrative costs and for operational costs. So and I understand that 90% is one of the highest in the nation, if not the highest, in medical loss ratio.
Yeah, I think we've heard that before. Yeah, that's
and
helpful.
Commissioner Lee, I can tell you too, I can assure you that as administrator of our fee-for-service program, we have several provider types. Behavioral health's not one of them right now, but those things change. We have several provider types where we struggle to get our fee-for-service members in to providers because all of our managed care organizations are paying a whole lot more than what's on the fee schedule, way over 100%, and in some cases up to 150% of some certain codes. So it's not, every provider is different, every provider type. It's a lot of same provider types in different areas. Depending on how easy it is, they have to meet, provider requirements. They have to meet accessibility requirements that's in their contracts. So every MCO is allowed to contract with each individual provider at different rates, depending on the need to provide those services in those areas.
Right. Yeah, thank you, Justin. So we have one other question, looking at everyone feeling the pain. What internal cuts, if any, are being made actually within DMS? Are you making any cuts to yourself?
Well, we have an administrative budget and we have a benefits budget, which, those are two different things. And we are keeping an eye on our administrative budget, because again, they're totally separate. But we've looked at, the cap on our personnel. Can we expand that? No, we don't have the funding to do that. We're looking at any and everything where we can see some savings in our administrative budget. And we currently operate at about a 2%. Our administrative is about 2% of our overall budgets, 2 to 3, I think, but if you think of what that is, that's pretty low, but we are looking at everything, for example, travel, that sort of thing, to make sure that we can stay within our administrative budget also.
Yeah. And as you say, you've got a heavier workload in many ways. That finishes the questions that we had put together in advance. Let me just see if anybody else. I see a gentleman on who had a question earlier about the AODEs, the alcohol and other drug entities, were not listed as a provider type, and I understand it's because they don't actually have a number. They're not actually, they operate under BHSOs or as BHSOs. Is that correct?
Justin shaking his head, yes.
That's correct. Yeah. AODs are licensed for Medicaid, or I shouldn't say licensed, they're enrolled in Medicaid as a BHSO.
Okay. All right. Because that question came up, and I just wanted to be sure I had told somebody that. And then I thought, in fact, I got some help with that answer. And then I thought, oh, I better check on that. And what about the SUD residential programs? I don't remember seeing them on the list.
I'd have to.
Sorry, this is Angela. Again, very similar to the AODEs. Those programs are enrolled under a BHSO or CMHC provider type. So they do not have their specific provider type. They would fall under one of those other providers listed on that letter.
Okay. So
it's a service, not necessarily a provider type, if that makes sense.
Okay, because we've had so much discussion, as you know, Angela, on the BH-TAC about different provider types. And I'm going to pick on ARC because they get picked on, and maybe appropriately, but they're under lots of scrutiny. So how is ARC listed as a provider, for instance? As a BHSO?
Yeah.
Even though they... Okay.
Yes.
I think that answers that question. Thank you. I just...
Yep.
Are there any other questions since we're here and we've got the commissioner captive?
So this is Michelle Sanborn. I have one question, and when we were talking about budget items, and Commissioner Lee mentioned there's the difference between administration, benefits, and services in the budget. And my question is, if the Medicaid benefits budget for 2026, 2027 was $1.4 million higher than the governor's requested budget, why are we cutting? So what's prompting these cuts when it looks like the General Assembly's budget came in higher than the House Bill 304?
That's a real good question, Michelle. And the answer to that is the devil's in the details, right? If you look at that bottom line, it absolutely looks like the General Assembly gave us more. But if you look at some of the line items in both of those bills, you'll notice there are some distinct differences. For example, the things that I mentioned before, the K-Cares program, the dental costs, those things, there's about $900,000 in the legislator's budget I mean, $900 million in the budget bill in the House Bill 500. That's different from what the governor's proposed budget was. So it's looking at each of those line items that are in there that shows what Medicaid would need to continue operating the program as it is right now. And the bottom line is that the legislative budget did not give us enough money to continue the operations as it is, in addition to funding for inflationary adjustments for providers that we have to make. For example, I mentioned the FQHCs, RHCs, they get an inflationary adjustment every year. It's a Medicare Economic Index, and so you can't just look at Medicaid and say, oh, it's flat funded here, and you can continue operating as you did in 26. So there are some distinct differences in those line items, and like I said, to the tune of about $900,000. So,
but again, so still help me, because if there's $900,000 and they gave you
Wait a minute,
1.4
it's
billion,
900,000?
900
million,
Million.
sorry, 900 million, and they
Yeah.
gave you 1.4 billion to cover it. Like, I'm still trying to understand where the hole is. Like,
so we're in 27 alone, we're going to have a $270 million hole in state funds only. I'll say that's state funds. So when you match that
Right.
up to the federal dollars that we draw down, that's where you get your thing. And Mr. Bechtel, I'm sorry, he's not on the call, but our CFO can explain that just a little bit better. But the bottom line is that they added that the budget bill, House Bill 500, added services and new projects without adding new funding for that. And so we're going to have to take the funding, all of that, the extra funding that was in there, and apply it for some of those new projects. And it's again, devil's in the details. And I know that somewhere you can find what the governor recommended and what it is actually in House Bill 500 and see those distinct differences.
yeah, so I tried to compare, and again, I just don't know the cost of some of the new projects, but it just still seemed like with a $1.4 billion addition, why wouldn't that cover what was in their budget language? And you're saying that it covered some of it, but not all of it. But do they know what they didn't cover? Are they aware specifically line by line of what they didn't cover?
Yeah, I think that there are conversations that are being had with with outside of me. There are conversations being held as to why this has happened. And for example, I did receive questions along those same lines, and we have outlined that. And again, the Medicaid program is just so complex, and the reimbursement structure is for each provider is so different and difficult, and it again, the devil is in the details, and I wish I could just say, well, this is exactly why. But the bottom line is there are new projects that we have to spend funding on that we have to take out of our allocated budget. And there's a difference between restricted funds, unrestricted funds, those sorts of things that are way beyond my comprehension. But we can, at the next meeting, we can definitely have our CFO on to explain some of those nuances.
Yeah, let's if you can put September 14th on his schedule. That's our next meeting, Commissioner, because I think it would be really, really helpful.
Yeah.
And there was a question about any willing provider, and it looks like Angela is responding to that, because I do get that question fairly frequently. Kentucky is an any willing provider state, so no insurance should be able to deny a contract to a provider just because there are enough providers in the area. But WellCare is doing just that and had already cut their rates to 90% of the Medicaid fee schedule. Then we get Aetna is also terminating, I guess, provider contracts without cause.
Okay, so this is Angie Parker with Medicaid.
Thank you.
There's two things to this. It's a new provider. They can't not contract with a new provider on these unless they do not meet these certain standards, which the exact conditions, quality standards, and reimbursement rates of the plan. Now, then you have the provider who is already a provider, right? So they typically have to have cause to term a provider. Now, part of that could be the provider doesn't want to accept the reimbursement rates. So that's where that comes into play. So but as we've talked about, I don't know if necessarily this meeting, but the contract is between the MCO and the provider, and what the provider is willing to accept and what they can negotiate with that MCO.
And if someone feels like the any willing provider is being not followed, let's say somebody new can't get accepted, or somebody gets terminated, who do they turn to with that, Angie?
Well, I mean, we have received some questions regarding that recently too, and also this is a Department of Insurance statute.
Mm-hmm.
So you can always contact us, obviously, and the Department of Insurance.
Yeah, and they have an ombudsman over there as well, right? They have a complaint form, as I recall, at DOI.
Yes, I believe so.
Insurance, yeah.
Angela, do you mind to drop your contact information or someone from your department in the chat so that we have that information?
Sure.
Thank you.
Yes, is that different from the normal DMS provider complaint? Because we filed a complaint. We did receive a response. We just haven't gotten anything else. And we've reached out and requested meetings, and we're not getting any response at this point.
We're also not getting support for the contract that we currently have with Aetna, with the other issues that we have going on.
And Lucy, you're saying the letter from Aetna specifically states that it's without cause, that they're terminating?
Yes, they're terminating effective 9/1 without cause. That's specifically what the letter states. And we have been a good standing provider without any known issues from them for a while. And I know several other providers have gotten this letter, BHSOs, and I know several other BHSOs received the same Humana reduction letter as well. So it's just happening all across the board.
And you are reaching out to the department, and did you say you hadn't received a response from?
I received an initial response that they would be reaching out to Aetna. I mean, we were literally emailing everybody, Commissioner Lee. So, I mean, we've emailed the provider complaint. We've emailed, of course, you. We've emailed the payers themselves, Aetna, since I haven't received a response since May on requesting a meeting with them. With Humana, we did meet with them after we filed our formal objection letter with new proposed rates. And there was no leadership team on that call. So we've emailed requesting another meeting, and I've sent a second objection to propose in new proposed rates. So it just feels like we're spinning our wheels.
Okay. And I apologize for that if the department hasn't been responsive. Maybe would you just reach out to me offline? Maybe you and I can set a time up to discuss. I'd really rather have a phone conversation or a Teams meeting or something with you, so we can take this offline, Lucy, and we'll I'll get more information. I think it helps with that verbal conversation rather than email. Sometimes stuff is lost in email. So
no, I know you're super busy, Commissioner Lee. So I apologize, but yes, okay. I will reach out and get something scheduled.
Yeah, just reach out to me, and we'll get something online, and maybe what we're talking about will help other providers and get some clarity.
Thank you, Commissioner.
Thank you, Commissioner.
But so, Angela, if the letter from the MCO says that a new provider is not being added because there already are enough providers, that's not legitimate.
No, it's not.
Okay. And that ought to go to DOI.
And like I said, we can also look into it as well.
Okay. Thank you very much.
And it sounds like, and I'm sorry, I didn't know who was the last person speaking, that a complaint has been sent in via that email address.
Yeah, it's Lucy with Isaiah House.
Okay. Thanks, Lucy.
I have a question also. The process of adding like a new service like your BHSO, once you have gotten that through Medicaid to add the MCO, they're taking longer than the 90 days. It's about 110 days, and then sending a letter stating that they need something else that was included in your first application with them. So like with WellCare, we've gotten back from other MCOs for our BHSO with the new NPI 2 hours, and it's not, we're just waiting in limbo and can't begin billing when we've already had our NPI sent to Medicaid. Now we're just waiting on the MCOs. It's been 115 days now, and I don't have an answer back. Is that something else that we should report there too?
Yeah. Yes, if it's been 115 days. And I know that says Kevin Eldridge, but I don't think that was Kevin speaking.
Who was that just was speaking?
This is Alyssa with Fuse Medical. We're a rural clinic in southeastern Kentucky. Just hopped on for some clarification and answers.
Okay, because it came up as Kevin Eldridge. Remember, your voice didn't sound like a Kevin. So that ought to happen within the 90 days. So it sounds like there's some games being played where they get right up to the 90 days and then say, oh, you need to send us so-and-so, and you've already said that, right?
Yes.
Okay.
Okay, and Alyssa, if you'll reach out to me by email, we'll get something scheduled too, so we can have this verbal conversation, so that nothing, so I don't get anything lost or misinterpret anything in email. Okay.
Okay.
And I've got one of the easiest email addresses in state government. I'll put it in the chat.
Yeah, no middle initial. That helps.
Yeah. It's Lisa Lee at ky.gov.
And Commissioner Lee is very responsive. I don't know when you ever sleep, but
thank you so much.
You're very welcome. Happy to help.
And I would ask for those providers that meet with Commissioner Lee and get it resolved, if you all would send me a quick email just to say, and I don't need to get into all the details, but when these things keep coming up with other people, it's helpful to know what the solution is. And Marcy just put my email in there. Mine is real easy too, kyadvocacy@gmail.com. Okay, in the interest of time, let's go on to rescinded approval of PAs for outpatient therapies. So Commissioner, this was our recommendation, our second recommendation to the MAC, and it really came up with a question. It started out with extended therapy services, but then it also came up with 90847 and 90853 were approved, I guess, originally by DMS, and we had said we didn't think that was good to have happen. And Steve was told at the April MAC meeting that it had been rescinded, and we've been back and forth and back and forth. And apparently, and I think Michelle, you have some new information also about what's happened with that, right?
Well, one of my providers has been told that 90847 and 90853 has been rescinded. One of my providers was told that those two codes were rescinded, but people still had to fill out and complete a prior auth, even though they're automatically being approved until the system is set. But then there was a new PA list on WellCare's website as of 7/1/26, and those two codes are not listed. So we're just not sure whether those codes are required to have a PA, not required, they're in the process. We don't know, but it's been 4 months and there's been no provider communication about whether or not 908, actually H004, 90847, 90853. The only thing that's out there about those is the implementation back in December when there was a bulletin on their website, but that's never been rescinded. And now those codes are not on their PA list, but frankly, those codes were never on their PA list because their list was October 1st, 2026. So all this is So there's new codes, there's no codes, there's back and forth, but just zero communication. So are we doing PAs or are we not? And if those have been rescinded, when can we know when that rescission date is?
I can answer, Commissioner,
Thanks,
if you don't
Angela.
mind. So yes, there was confusion about the codes early on, and initially H0004 was rescinded, and an email was sent to the MCO on March 19th that specific code was to be rescinded. I know after that there was had been discussion. So what about 90847, 90853? Well, an email was sent to that MCO on June 15th stating effective immediately 90847 and 90853 PA is to be rescinded. So neither of the three codes, none of them for this MCO should be requesting a prior authorization.
And we made this is Beth from WellCare. We made all those changes effective immediately. However, the systems cannot be changed immediately. Those take time to have the changes made. And so we are, still asking for people when they need the codes to request those through the regular channels. They are approved, and that will allow the claims to be paid until the system catches up with that. And so the providers are told that when they do call in, and they can see that when they log into the provider portal, which is not always the same information that is on the public facing website, which is, I think, what you're looking at, Michelle.
And I did want to say that is an approved method from the Department for Medicaid Services for our managed care organization partners. Whenever they have a prior authorization that is removed, either through a regulation or through DMS policy, that they have time to make those changes in the system. So what they usually do is you do have to kind of, pre-send some stuff in, but it's automatically approved until they get their system updated.
Yeah, this is Steve Shannon. This is the first I've heard of this. We've talked about this many, many times. It's the first I've heard that there's a time frame that allows the MCO to require, and we never heard, because we had heard previously, you must have a PA. We never heard you must have a PA. It will be approved. So just submit one, and because it's not really required, but until the system. So I'm glad to hear that. But we've been talking about this for months. Yeah. And we never got to the message we just got from you, Justin, and from you, Beth. So I think that's the frustration, is we were told they were rescinded and we still had to do one. So that was the disconnect, I think. We never made the connection that the MCO system was given time, but we didn't know that. Michelle, go ahead.
When will the system be ready? Because some of my providers were told by WellCare, because they forwarded me emails that said they no longer had to do a PA for those two codes. So I'm a little concerned that they're not going to do them, and then they're going to have to go back and do them. And then also, is there just a way to put like a simple letter or number in the box just to make it, quick, so that they can, kind of override the system in a sense while we're waiting?
I'm sorry. What do you mean a letter? I'm not sure I understand.
So like putting an X in the box that pulls up for a PA requirement. I mean, why would you have to complete a full prior auth if it's automatic when really it's just a systems thing? Does that make sense?
I think you're talking about putting something in the auth field with the incoming claim. Is that what you're referring to?
In the field, yes, that's correct.
I mean, in order for us to get notice, they have to, fill out the form. If they want to put in that form that as their note of why they're requesting it, they could do that.
Okay. So when will the system be up and running? By the 15th?
We don't know. Right now, we don't have an ETA on that.
Yeah, this is a source of frustration. I hear from CMHCs that you think something happens and it doesn't happen. You got to do the whole work anyway, but it doesn't sound like that's necessary. So again, it's an administrative cost imposed by a payer whose system can't meet the need. We're waiting on some tech person to change the system. So we have additional administrative cost that is completely unfounded, completely.
When the change is to take effect immediately, that's when we, it does take time for us to make that change. When there's notice, we can plan ahead. So this is kind of the workaround. Like Justin said, when, we want to make the change effective immediately, we still have to kind of go through the process until the system catches up.
So that's why we're asking, is there some further workaround? Because it's not really a workaround.
No, it's not. It's the same process.
There is no workaround, Beth, until your system gets done. That's why we're asking.
They're automatically approved is the workaround.
But they still have to go through the process. That's what we're saying, of submitting the darn form.
Yeah, we don't know that they need it unless they tell us and submit the form.
Yeah, so the only way, and we do deal with that too for fee for service. The only way we can do that for Medicaid would be to start the prior authorization. We just start that at a later date, right? So we could say, hey, this is going to take effect December 1st, and then make those system changes effective, and then December 1st, 2026. Everybody's kind of on the same page. Or we could just say we're going to implement it now and everybody's going to get approved automatically, but you still got to go through that process, until we get our system changed. We have the same thing with fee schedules. Our fee schedules will go into effect. They'll retro back January 1st of each year for most fee schedules. But a lot of times those changes will go out on the actual fee schedule in April, and then the actual system change won't take place until like October. So or September. So those changes are, those system changes are complex. They take a lot of time. And every single time we make a system change, it costs us money too. So we understand that it's administratively burdensome for our providers. And that's what we're trying to remove administrative burdens and hurdles, but it takes time and money for us to do those things as well. So we do appreciate your all's patience as we get those things done.
I just don't think it's really accurate to say that a change has been implemented if the technological component is not there. If individuals are still being forced to follow the steps and whatnot, then the change has not really been implemented. The technological component has to be there to say that change has been affected as well.
And since we're talking about this with the fee schedule, with the 4% reductions that we're going to potentially see as providers anyways, I mean, this all goes hand in hand with this. We still have to wait for that system to update when that fee schedule change comes. And there are many times that we are spending 6 months or longer waiting on payment from MCOs because their system hasn't been able to adapt to those fee schedule changes. And we're on biweekly phone calls with provider reps trying to get payment on services that had already been rendered from 6 months ago. So, I mean, it's all encompassing from an off perspective and fee schedule changes with the administrative burden that we face as providers.
Yeah, I think that's a good point. And I think you're right, with the reduction or in reimbursement coming, it just makes it that much harder. So there's a question in here about the 90847. We still have to submit the PA form, treatment plan, and biopsychosocial. It's a huge amount of time to request a code that is a low paying event code and is, even though it's going to be approved. Right, Kelly? Yeah.
Yes. I mean,
we can certainly take that back with DMS and see if, maybe that's a future policy change for us to make sure that any implementation of anything like that doesn't occur until after for PAs doesn't occur until after the technology is already in place. So we'll take that back and maybe discuss that next meeting.
All right, we'll
Just
keep
to-
it on. Somebody had a question? Yeah.
I think Justin is right in that they're trying. Like the step is moving in the right direction if they're automatically done, and it does take time for systems. But I think what we want to know is how long is that, and is there a way to kind of what I would say override or the system by putting, like I said, an X or a zero in the box, the field that is asking for that so that it goes through and they get that, but that's automatically done. And so that keeps people from having to do work. So we're just trying to help streamline because again, I understand that you guys have to change your systems and thank you for doing it for the next however long length of time that would take. Um, I don't want to continue those PAs for another 6 months while we wait. So I get what you're saying. So thanks, but we're just trying to figure out, is there a better way, an easier way to eliminate that administrative burden? So thanks.
Sure. And like I said, we'll take it back, talk about it. Again, maybe it's a better decision to wait until those things are done before we announce something like that, or maybe we give a future date instead of trying to do what we've done. But we'll talk about it. We'll discuss it. And I do see Miss Kathy Anderson had a question in the chat. Our authorizations are we set those in the fee for service system. But if a managed care organization requests to do a prior authorization on a code that we don't prior authorize, all we request is that they submit us some type of reasoning as to why. It could be anything. It could be a increased utilization in that for that code that they can't really account for the reasoning why. It could be suspected fraud, waste, or abuse. It could be for some type of tracking mechanism that they need. So we do review each one of those on a case by case basis, and you'll see, fee for service may not require a PA, but this MCL might, and this MCL won't, and this MCL. So we do allow them to have that opportunity, but we do review each one of those.
When you actually give permission, right, Justin, after you look at
That's
what they
correct.
submit?
Yeah, they have to submit their policies through a system that we review.
Yeah. And Kathy, you're saying the PAs were reinstated by Kentucky Medicaid?
Yes, that was via House Bill 695.
Oh, well, yeah, right. Well, but you may remember that then Secretary Eric Friedlander was already communicating with us that he
Right.
thought it was time for the PAs. So it was going to happen one way or the other. I think the time frame from 695 was quicker than it would have been with
The other.
cabinet leading it. And I think there were maybe more exemptions that were going to be in the cabinet version, but the legislators apparently know better what's needed in services. I'm going to get snarky here, so let's go on to the next question. An update on MCO audits of providers, particularly prepayment reviews, and the MCO authority for those recoupments. And I think we had requested, remind me, Mandy or Michelle, didn't we, or Bart? Somebody had asked for the actual
Yes.
authority, right?
Yeah, the reg or the statute.
Yeah, what the authority was for the recoupments, because it seemed that it was much broader than we would have imagined. And so we'd just like to see what the specific language is that defines the authority for the MCOs for recoupments. And it kind of started from recoupment on administrative items, not necessarily items of the service wasn't delivered or it was delivered by the wrong, incorrect person, didn't have the correct credential. Those are intentionally not provided. Some of those types of things that would fall into waste, fraud, or abuse, but just things that were administrative findings that need to be corrected, but don't seem like they would rise to the level of recouping for the services that was actually delivered and documented. And maybe the signature was a day late, but the service was clearly delivered by a properly credentialed person, met medical necessity, all those things. To be recouped on that seems to be excessive, and seems like it'd be better for a corrective action plan or provider education as opposed to recouping the payment for the claims for a service that was delivered.
Danny, do we have anybody from the MCO branch on or that area?
I do
This
believe
is,
Chelsea. I'm sorry, go ahead.
I'm sorry, Danny. This is Jennifer Dudinsky, our program integrity director, has been communicating with this group prior to, and she's out of the office today. So hopefully we can get some definitive information back to you, Dr. Schuster and Bart and Michelle and Steve, because I know you were all on that preliminary meeting.
Right.
Thank you, Angie.
Yeah, that would be really helpful. Thank you.
And I think not only it's around recoupment, but it's also around prepayment audits, because it seems like there's prepayment audits going on, but there's also prepayment reviews going on. And we're trying to kind of understand, we see the authority and the information in the contract around prepayment reviews, but I don't see any language or understand the processes around a prepayment audit.
So
And
Danny,
this
make
is
sure that
true.
Ms. Dudinsky gets this agenda topic and get some information back to the TAC.
Absolutely.
And do you all do a interim TAC meeting, Dr. Schuster, for this TAC?
We just started doing
Okay.
one that's
Okay.
a smaller group that was
Yeah.
that Dr. Hoffman has
Maybe we can
convened.
get some information to you all
Yeah,
before
and
that.
Jennifer Dudinsky's been on it, and Angela's
Okay.
been on it, and so forth. It's been very helpful.
All right,
But we're
good,
just
good.
following up so that the rest of the behavioral health community knows that it has been very helpful, and we will keep doing it. Thank you.
Real fast, Dr. Schuster, on that topic, just so folks know, this is another area where MCOs do have to request to put a provider on prepayment review and wait for that to be approved before that process starts.
So yeah, so we're supportive and glad that that's happening. I think what's happening is that there are MCOs that are doing prepayment audits, and they're not really, there's no process for that. There's no approval. So we don't know so that there's basically one or two or three claims and they're not paying them, but then they're asking for the whole record to review the whole record. And so we're just trying to figure out what are the timeframes for that? What's the appeals process for that? Someone mentioned the other day that we would just follow the audit process. And I would say, then you pay us and then we'll follow the audit process, policies and procedures, and then we're clear and we know what that is. But they're going months and months without payment from the MCOs because they're doing a prepayment audit,
Yeah,
not a review.
it's taken us several meetings to kind of get to. We're talking about two different things here, apparently.
Right. I think it's been the language, Krista, that
It's been
the
the language
MCOs may be.
that some of the MCOs are using in their letters to
Right.
providers, and maybe misnaming or using language that doesn't really fit.
And I know one MCO in particular was doing that, and I believe Chelsea AG with Health Plan Oversight did address that with that MCO. So I don't know if that's still happening, but
Oh, okay.
Michelle, I think you were saying that there were still some, because we talked about claim denials being different than a prepayment review. And so I think it's, and I'm not going to speak for Dr. Schuster or Michelle, but it sounds like it's potentially language that is being used.
So maybe it's claim denials that are happening. And so maybe then if you could provide information about the claims denial process. So I don't know, it's happening with 4 or 5 or 6 of my agencies. It's not a lot of codes, but it's enough that, again, they're paying for therapy, they're paying their therapist to provide the therapy, and then they're going months without getting paid over something that is clearly an error. I mean, there's there's nothing wrong with anything that they've done, and the MCO just continues to push back and push back and push back and say that something's wrong, and it's not. There's nothing wrong. And so it's just a concern that we can't go through all that process without them being paid. Why can't they be paid? And then we talk about all the errors and mistakes that we're all making after we're paid.
Yeah, I think.
Dr. Schuster.
Yeah.
My name is Erin Lovell, and I'm one of the MCO liaisons in the contract monitoring branch. And I will say, I know that this has been an issue with a couple of MCOs in the past with the letters and the confusion it's created. I know for a fact one MCO has corrected it, another, I believe, is in the process. And we have also asked for examples from these providers showing this. I'm going to drop our provider inbox email address into the chat so these providers can email us, send us those letters, and show us that they are still actively receiving those after the department's had the conversation with them. So to any providers that have the letters that indicate it's an audit rather than a review or vice versa, please send those to the contract monitoring branch so we can review those. Examples are important. We need, we need more than anecdotes. So I'm going to drop that in there and we will look for those in the inbox. So thank you very much.
Thank you,
Well,
Erin.
thank you. Yeah, we appreciate that. And, I think this little group that's been meeting with Dr. Hoffman and her folks have been very good about having examples for sure. So we will certainly follow through, but I appreciate your being on, Aaron. What I started to say was, and we keep saying this, if we're all on the same team and we all want people to get services, it feels like to the providers that we just really need to be clear on what the rules are. And that's what we keep coming back to. That's why we've gotten into this whole thing about, is this a prepayment audit or is this a prepayment review? And is it done, so it's holding up payment. And is there a way? We almost would rather have an audit because then at least somebody's gotten paid. And Bart has made a good point of, it feels to me that when the reason for not getting paid and for holding up things for months at a time in many cases is a claim that the supervisor didn't sign in the right box or they didn't put their credential in or, purely administrative kinds of things. When people have delivered a medically necessary service that is not being questioned, and was approved, and we all have to assume it was medically necessary and the person needed it and got it and so forth. It feels like that's what we're trying to kind of cut back on some of that, because it's hard enough to be a provider, and with the 4% cut coming, I really, really, really worry that we're going to lose providers, we're going to lose services. And the people of Kentucky that are Medicaid recipients that need behavioral health services are really going to suffer like hell.
Dr. Schuster, I appreciate that. One of the things that we did identify and we did understand about that, we want people that are doing a good job and providing good services to get paid. So we identified a lot of LOIs for prior authorizations due to just the type of thing you said. Somebody didn't sign the right spot, didn't put the right information in. And we actually created a project, and we're working on kind of expanding that and with working on our MCO partners in the future. We're kind of getting that nailed down for our fee for service. Where any provider that gets 10% or more LOIs on their PAs, we have a individual training with them to go over exactly what they're doing wrong on those PAs, how they can correct it, what are some easy tips and tricks. get them to ask questions, what they're struggling with, show them here's all the reasons why those LOIs came back, and here's what you can do to fix those moving forward. And we've reduced the amount of LOIs in our fee for service system by about 50% just in the few months that we've started that. So it's been a huge administrative ease for our providers, especially the ones that went through that program. We've seen some of those, rates were up to 50% of the PAs are getting kicked back for some of those providers for LOIs, and now they have almost zero. So it's made a big difference, and we're going to try to expand that out. So we do recognize these things, and we are trying to help as much as we can.
I really appreciate that, Justin. That's exactly what I think
Yeah,
what we're all, if a provider is not doing what they're supposed to be doing, I think all of us collectively want that provider to get the education they need. And if it keeps coming up and keeps coming up and people are not getting quality services, or there is any hint of fraud, waste, and particularly fraud and abuse, we want that provider to be handled accordingly. But I
sure.
think,
And it's not, it's not just the fraud, waste, and abuse. When CMS comes and does an audit, and they say, well, you paid this individual, but it's the wrong, it's the wrong ICN number, or this signature's not there. It's over here. It doesn't matter. It's supposed to be here. Then they penalize us, and then they take money from the state. They take money from the MCOs, and so, they have to make sure that in their records all those things are exact too. So there's a lot of different, things involved with that. Everything has to be kind of right. And that's why it's important for us to do a good job making sure that you all know, and that's something we look at constantly. We look at all our provider rules when you go to submit your claims in our fee for service system. You have a provider billing manual, and we try to be very specific in that. We're constantly updating that to make it more specific, fix any issues, find problems. We put them in there, and I know our MCO partners doing the same thing. And if you see something, reach out to them and say, hey, listen, it'd be helpful if you put this in there, because I promise you our MCO partners would much rather it go smoother than to have it not. It's an administrative burden for them too.
Yeah. Well, I appreciate that. I'm going to move on to a couple of things. We're going to hold up on the medical necessity criteria till we hear back on our recommendation. Michelle, you wanted the access to commercial bypass list to be on. Are we still having problems with that?
So we had put one together a while back, and folks have asked for an updated one. And when we went to try to do an updated one, we've been told that we can no longer do that from some of the MCOs. So just wanted to just kind of put that out there, since I know providers have been looking at that, but it does seem to be that commercial bypass codes are a thing of the past from what we're hearing.
Yeah, and I mean, there's a Medicare bypass list. We like to see that as well. I think it will just help the process. All providers got to see that, commercial as well. But we've been told we can't see the Medicare bypass list.
So is this the one that our friend Herb Ellis over at Humana helped us with?
I am on. Yeah, don't blame the messenger though. I'll say on this one.
I was waiting for you to get on, Herb, so I could take a pot.
You ever notice his little icon you see for Herb? That's intended to be intimidating.
That's right. That was intended, not just joking. Yeah, I mean, again, the MCOs, we abide by what we are told to do. I think KDMS has explained this about the expectations for primary, due diligence for primary coverage review, since Medicaid is ultimately the payer of last resort. So there's a bypass process that all the MCOs follow. It's made simplified by a list that's provided by KDMS, but it's not necessarily mean that that's a list that we would publish out and say, hey, here's the background logic that we're using to follow what we've been advised to do in our claim systems. And I'll default that to Justin. Anybody else wants to talk about that?
Sure. Thank you, Mr. Ellis. The issue is that CMS is very hesitant to allow who we give that to. We give that to our MCO partners to help with billing, and we use that for fee for service billing. But it's not an exact science. We still have to review that. It's kind of a case by case basis type thing. It goes through a lot of different ifs, ands, or buts, and that list can change on a daily basis sometimes. So it's not really something we can publish unless we have specific CMS approval for it, which they have never really given us. And so, that's kind of why we don't have a published bypass list at this time. If at any time that changes in the future, we'd be glad to share it. But we have to get permission from CMS to do that. And as of right now, we don't have that in place.
So we have to wait until the leadership at CMS changes or something happens, right? Okay.
And if I'll just add a little nuance to that, remember, CMS is specific to the fee for service side. You do have Medicare Advantage plans, which actually does cover some of these services that would be considered bypassable. So in that scenario, the Medicaid plan ends up paying primary for something that really is actually covered primary under Medicare Advantage. So there's definitely an opportunity to offset those dollars more appropriately to those Medicare Advantage plans if we do this correctly.
Okay, well, that's a good hint. Yeah. All right. Well, thank you. How about some waiver stuff? Leslie, I think you're back with us. I don't know who's doing the 1915.
Anne is on today for the
Oh, you can't
for the
see me.
SMI.
Sorry.
Because I think Tanya's gone, right?
She's retired a second time.
I was
Yes.
going to say, I'm never going to criticize anybody who retires more than once, since, I may have retired 5 or 6 times already. So, but Ann, we're always glad to see you.
Well, I'm glad to be here. So let me just give you a little update. We do this weekly with DMS, so we want to make sure we're handing you the same things. As of Friday, we have 203 individuals enrolled. So that person could be in process with assessment, or they could be in the process of selecting their case manager, working towards those person-centered service plans, and then having them developed. 107 of those 203 have person-centered service plans done. So that to me means they're potentially receiving services. So
Right.
on the provider update side, we have 38 certification applications in process. 13 were submitted last week. So we've had an influx. Yes. And so we have 20 providers certified right now. 18 of those are Medicaid enrolled. And as you all know, we are currently accepting individual referrals in Pathways region, Kentucky River, New Vista, 7 counties, and Pennyroyal. And I'm glad to announce here first, Dr. Schuster, beginning Monday, July 13th, we'll be accepting referrals in Adonta region.
Oh, wonderful. So we're making our way. We still need to get out west.
We are
Pennyroyal,
strategizing how to do that. Yes, ma'am.
Okay. All right.
I'm
That's
sorry. This is Beth from WellCare. I've lost the ability to raise my hand, but I had a question. The child waiver.
We haven't gotten to it yet.
Okay, thank you.
Yeah, just hold on a second. Okay.
I don't know what happened to that feature. I apologize.
Yeah, that's all right. So, and that looks good. Do we have any of the participants in supported housing?
Yes, we do have some in residential services. Yes, ma'am.
Wow.
I don't have that number for you, but yeah, we are still, we're always going to be looking for providers to do residential.
Right.
But we're working, with our psych hospitals, personal care homes, we're prioritizing them. We've had a few little glitches with some eligibility things, but luckily, as I said, our partner DMS, they help us figure it out as always. So
That's
yeah,
great.
it's exciting.
Yeah, thank you. I appreciate that.
You're welcome.
Reentry waiver. And Steve, I know you had your reentry TAC this morning.
We did. And there's been a lot of in-reach at facilities. I don't know if anyone else is on.
Sparrow, I see Angela's on.
Yeah. But a lot of in-reach, all sorts of facilities, they're following up some people that have already been released. Still, and I don't think I remember, maybe said this the last BHTAC. In corrections world, the release date is really fluid. And it depends on some time off credits for whatever it is, taking classes, whatever. So when that happens, you don't really know the date. Also, the process involved, if someone's up for parole, you can start the reentry waiver services 2 months before that possible parole hearing. But about 30% of the folks get parole, so 70 don't. So then, those folks are moved into a different category. I think those are some logistic things, but they have moved people out. One story we heard, the person moved out, they helped them get into a recovery housing program, and they're now working part-time. That's really what the objective is. So, again, it went live April 1. So we're still really early in the process. We appreciate our MCO friends who have made a lot of visits to all the facilities. I think most MCO reported into all DOC facilities, and moving forward. So I think we're having something to talk about besides the waiver application process. So it's exciting news.
Yeah, that's great. Angela, do you have anything you want to add?
Yeah, thanks. Sorry. I know we had a great discussion this morning. Echo everything Steve said, and especially we're seeing great collaboration with our MCO partners and DOC partners. We talk a lot about DOC because that is our largest population. Our DJJ Youth Development Centers, again, is a smaller. We're looking at, sometimes they might have 200 youth that leave those YDCs in a year. So it is a smaller group. Just to give you some quick numbers, as of yesterday, since our April 1st implementation, we've had 800 individuals that were enrolled in a pre-release eligibility period, which again is a very large number. And then we have had 670 of those individuals that had closed pre-release eligibility segments. So what we're really trying to understand about those numbers right now is we have to keep in mind what Steve said. Some of those, and a good portion, right, of those individuals were actually released. A large portion aren't released, and again, still remain in custody and are deferred. So trying again to kind of understand what that looks like, what the population looks like. So I'll give you that information that we do have. In addition to, of those, only 26 of those were our 21 and under CAA youth. So 21 years and younger. So that shows you again the population there really is our adult population. And just again to echo the work that the MCOs have done in just June alone. We had 269 individuals participating in pre-release in-case management services. And they did collectively make 216 in-person visits. So being inside in the facility behind the walls. So they are again making strides to get their case managers in those areas, working again to schedule. We know accessing those facilities again is very different than how we access and see others in the community. So I'll pause there, but just a lot of work, and just want to make sure that they have the recognition and what they're
and through their efforts, a very small number of people are refusing to receive case management services. So again, the MCOs, and they work closely with the Department of Corrections reentry team. But of that 216, I think the number was almost 209 or 8 that accepted case management. So 7 or to whatever number rejected it, which is their choice. So the idea that have someplace, someone to talk to when you get before you get out, and then kind of there for you afterwards. We're excited about it. Appreciate the good work that DOC and MCOs and Angela Sparrow and her team who brought this forward.
Yeah. It's
Long time process, right, Angela?
That is exciting. There was a time when we weren't sure it was ever going to get out the door, if you all remember. I'm sure you remember it well. So thank you, Angela, and thank you, Steve. And now
Have
on
any
to
of these folks moved into mental health court? Is that any of the? I know that when we talked about the reentry waiver, we had talked to them about case management and setting them up with their meds and all that kind of. But I don't remember if we had talked about mental health court options.
Right
after
right now the program really again for the 1115 services and population are those in the state prisons. So again, and not in our local jails and AOC. Again, certainly at release, they have parole conditions and supervision requirements and things like that are required to be met. But again, that's kind of the population. Does that help any, Valerie?
Angela, I just say to Valerie that I have received recent emails, text messages asking from court officials and or mental health court employees about RISE and the referral process and those kinds of things. So I know that they know now. It's just when it catches on, it'll be a wildfire. So yeah.
Yeah, about RISE, Leslie, or
Yeah.
about
Yes, just
reentry?
asking what
About RISE.
opportunity about RISE. Yeah, it's so the mental health folks that are involved in the court systems are asking for what opportunities, if that's kind of what Valerie was asking, what opportunities they have through like mental health court to go into the community. So I know that's it's separate from reentry, but we're hearing, there are connections there as well.
Yeah, good. All right, good question, Valerie. Thank you. And now the child waiver, because I think Beth is interested in that.
I have sent the information to Danny to send out to you all, I was going to say, Danny, can you make me give me the capability to share? I can share this document and then you can send it out to him instead of, I can't, for some reason, it won't let me copy and paste.
All right, awesome. I was able to get it in the chat, and then I've also given you
Oh,
the
you did?
ability
Well, I
to
won't do
share
that.
if you'd like.
I will just, okay. Well,
yeah, it's in the chat, I see.
Let me see just a second. There we are. I'll just go over Carmen's not available, so I
Hi.
will just go
Was
over
it the child waiver time?
Oh,
yes.
Yep.
Now
Sorry.
it's child waiver time. Yeah.
Okay. So we have had questions come up, and I know each situation is different, but people have wondered about if there is another family member in the home, such as a parent or another child that is on waiver, would that child still be eligible for a different waiver? So I'm going to make a situation up because I don't actually know it. Like if father is on, the TBI waiver or, would they be eligible, or the RISE waiver? Would they be eligible for the child waiver for that child?
So the child should be eligible for the waiver that they're applying for. Are you saying if mom or dad are on a waiver?
Yeah, the parents were concerned that they would lose the waiver services that the parent had if they applied for another waiver. They could have more than one family member in the home on a waiver service. And I didn't think
we can take a look at that, but I don't. I'll take that back. Or if you can send me the example, but I think we've had that situation to come up before, or I know we've had more than one child in a home. I don't see where that would overlap because there would be for brain injury there would be this just example too. There would be a own set of criteria for the adult dad, right? Than there would be for the child and the child waiver.
Well, and different services are being offered too. Yeah,
that's correct. It's not duplicative services.
I mean, obviously, what we encourage them to do is, get on the list, get the assessment. We can ask all those questions, but sometimes they're nervous that they'll lose something and don't even want to apply. So I just kind of wanted to make sure.
Yeah, I don't see that being an issue. Yeah. If you want to send me an email though, and I'll double check. But right off the bat, I've been in waiver world a long time. think that that's even an issue there.
That's so interesting because I've never heard that come up before. Leslie, you have much more experience than I do.
Yeah, I mean, I think I've had a parent on HCB before while maybe a child's on Michelle P or something like that. But let us double check. And I think the main thing is that the services don't overlap or that the parents are getting paid in some way for providing services to another waiver. But child doesn't have a PDS service, so that shouldn't be an issue.
All right.
Okay,
Thank you.
and so just send me Beth to send me information. Can
Okay.
you see my screen, Dr. Schuster?
Yes.
Okay, this is just really quick. I thought you'd be interested. So provider applications, we've had 16, one still in review, one additional information we're waiting on. I think that's the same one. Certified providers are 10 and providers denied have been 5 for various reasons. Participant applications, 63 in review, 23 or request for additional information, never participants waiting are 3. Approved participants are 21. Applicants denied are 7. I did look this yesterday morning, I believe it was, before we had government contract review, and I think I had 9 of the 21 had requested residential services and or were in DCBS custody. So that's a large portion there. Majority do have autism as diagnosis. I'm thinking it was a really high percentage. It was the most. So just letting you know there. Waiver wait list. So I'm going to go over this with you, and then I wanted to explain because you're probably going to catch it before I say it, Dr. Schuster. On funded slots, that's the part I'll go over with you just in a little while. I've got the total wait list numbers, the total funded slots, filled slots, and you know how that works. We've got lots of churn going on, and then the total wait list numbers there. So total is 22,218. But if you take an unduplicated look at these members, which means they may be receiving Michelle P, but they're also on the SCL waiver, so it's 18,769. One of the things we ran early this morning, and the numbers were just a little bit different because these numbers have already changed since that we pulled this information. It's already changed. Almost 13,000 are already on Medicaid, so that means they don't have to be waiting. They can receive our state plan services. They're receiving other benefits. So I wanted to let you know that. So House Bill 500 did give us small amount of slots. You're aware of that. 405 total for a 2-year period of time. We went ahead and requested, made an amendment to CMS. It did not require public comment before I get that question because we're adding something, not taking it away, and not taking away a methodology of payment or anything like that. So as you can see, here are the numbers for HCB, Michelle P waiver, and SCL for the next 2 years. We did submit that and got it approved on June the 30th to be effective July 1. So with that said, I have added in the slots to the funded slots above. So I figured you would catch that fairly quickly.
Right.
They're already included. So they're already in these numbers up here for year 1.
Okay, great.
That's it. It's going well. We did get regs passed yesterday through ours. We will still have to go through health and welfare. So.
And the regs were on
the child waiver.
Okay.
Were approved through ours yesterday. The Administrative Regulation Review Committee,
Right.
and they'll still go through health and welfare.
Yeah. Okay.
There's still a concern about us not including PDS services in this waiver, and as you're aware, they're usually PDS services are non-medical in nature or non-clinical. We have 7 waivers here in Kentucky, and 2 do not have PDS included. So I just wanted to let you know that we felt like because this was compared to psychiatric level of care or hospital level of care, that this is a little more medical, a little more clinical than other waivers might be. So we did not include it. So I just wanted, that seems to be on a lot of folks' mind. If you're in residential services, you're not eligible for PDS anyway, and that's the majority of what we're getting are exhausted parents who are looking for placement, or DCBS custody looking for placement.
Right, right. I knew that the autism percentage was high because that testimony that you all provided at the interim joint family and children's.
I have it somewhere.
We had that huge meeting on autism. The whole thing was on autism, actually.
Yeah, at that time that day, it was 50%.
Yeah, yeah.
A little bit more, actually, a little bit, just a little over 50% had autism diagnosis, and I had like just maybe 2 that had dual SED IDD.
Yeah.
But the waiver's going well. We're excited about it. Long time coming. It's not as large as anybody would like for it to be, and so that's just where we are right now. We were given 14.7 million to develop a waiver in benefits only. That's not been an issue. We created it and developed the waiver knowing that we wouldn't have admin. So I mean, that's not been an issue. But that's the best we could do with the comparison rate that we were given and to get CMS to approve it.
Right.
Thank you.
All right. Thank you very much.
Yes, ma'am.
Leslie, appreciate it. Just very briefly, the Moab Medicaid Oversight and Advisory Board had not met since March, and we had our first meeting on June 24th, and it was a humdinger. The actual agenda for the Moab meeting was not all that remarkable, although Commissioner Lee and Steve Bechtel were there to answer lots of questions about spending and the budget and so forth. But the announcement had gone out that the Lee Specialty Clinic their funding was being cut by $4.5 million out of a $7.5 million annual budget. And they were told that 1,000 of their 1,500 patients should be discharged. And the problem is that that's a multidisciplinary clinic, the only one of its kind in the state that sees people with severe intellectual developmental disabilities. And so for those of you who remember our 874K Disabilities Coalition huge rallies that we used to have in Frankfurt before, from 2001 to 2020 when we had COVID, it reminded you of that. It was the entire 154, which probably holds 75 people, was crammed. And then they overflowed first into 2 rooms, and then they added a room, and then they added another room. So we had that many people. I suspect it was well over 200 people and a lot of consumers there. And so a lot of people had signed up to speak, and I was concerned because we typically only have 15 minutes, and so 5 people get to speak. But we finished the meeting early, and Chairman Ken Fleming called on as many people as he could. We went a little bit over time, so probably well over 20 people spoke, and it was heart-wrenching, to be honest, with people saying, and these are adults, and these are people that still live at home or still live in the community. So they're saving Medicaid dollars already because they're not in nursing homes or in ICFs and so forth. But they did a great job, and they really did a super job of not pointing fingers at either the administration, the cabinet, the governor, or the legislature. I think to a person, with maybe one exception, they said, the ball's been dropped and we don't want to be the ball, and we don't want you to catch us in the middle. And all we're doing is asking that somebody find a solution here. And the very next day, the governor found some money. He took it out of the budget for some renovation that was in the budget for the annex parking garage, actually. And since I park in that parking garage, I was a little bit nervous because that parking garage always acts like it's going to fall over. But anyway, So huge, huge victory for the advocates. And I was delighted to see it from that standpoint. And I think they're going to continue because they're very concerned about the 4% cut for waiver providers, because all of those HCBS waivers are on the chopping block in terms of waiver providers. And I think there's a lot of concern about the lowest paid providers, the ones that really do the tough personal care work in those waivers, and that we're going to have agencies closing and waiver participants are going to not be able to get services as well as they need to. So the other news is that they have appointed now the membership, and we can make that available to you, of the 2 subcommittees in the work group. There's one subcommittee on managing the waiver wait list. There's another one on non-emergency medical transportation, NEMT, which is always a topic of concern. I think the MAC has talked about this for as long as I've been going to MAC meetings, because a lot of Medicaid members miss their transportation, or it doesn't come on time, or they get left, or whatever happens, and then they get in trouble with their providers and so forth. So that is a system that really needs to be improved. Our very own Steve Shannon has been appointed as a member of the Medicaid waitlist management group. Amy Stade, who many of you know, that heads up CAP, the Kentucky Association of Private Providers. And then there's also a steering committee or a work group that is data transparency, to create a dashboard. There's been a lot of controversy in the MOAB meetings about whether we're improving the health of Kentuckians or not. And so Mark Birdwhistle, who many of you know from UK, and Ken Marshall from U of L are on that committee, as well as Allison Adams, who's the executive director of the Foundation for a Healthy Kentucky, and then some cabinet people. And I think it'll be a good, and those are going to be open meetings. So on July 17th, the MOAB meeting has actually been canceled, but one of the work groups is meeting on the 16th and the other 2 are meeting on the 17th. So stay tuned. We will meet again in August. Any new recommendations to the MAC? Anybody have anything? Any of our voting members?
Yeah, I don't think so, because we're still pending the 3 we made, right? In May.
Yeah.
I think that may drive next steps.
Yeah. Any new business to come before the TAC? Seems like we had lots of participation, lots of topics, many of which we will keep on the agenda. Any formulary issues under old business? Val, are you hearing anything about access to medications?
Only one I'm hearing is the new drug for schizophrenia,
Caplyta?
No, shoot. Shoot. It's the brand new one that's out for schizophrenia. Is just out of touch for anybody who wants to try it. Shoot, I can't remember it.
Okay.
Cobenfy. Yes.
Yeah.
Yes, Cobenfy. Yes, it's out of touch for anybody yet.
Out of touch in terms of cost? So obviously not on the preferred drug list yet. Maybe won't be for quite a while. Okay. But people are able to get their treating drugs. Are people able to get their long-acting injectable if that's what they need?
So far so good. So far so good.
Okay. I have to say we've had relatively little concerns in the formulary area since we went to the pharmacy benefit manager. I mean, it seems like we used to have just one thing after another. So our the MAC will be meeting August 6th at 10 a.m. And that meeting now will be 2.5 hours. We tried to cram it into 2 hours and we kept running over. So they meet on the months opposite this meeting, and they're on the first Thursday of the month, so August. And then our next BH-TAC meeting is September 10th. I think I told the commissioner 14th. I'll check that with her. So thank you all, and welcome, Greg. We're very glad to have you with us. And thank you all to the voting members and to all of you who are here and participated. There's some follow-up items that we will get out to you, and also some follow-up, I think, that we asked the commissioner for. But we will definitely send in a data request, both in terms of consumer data and provider data, to at least get some baselines established before these cuts come. And there may be lots of groups are talking about, there may be a sign-on letter for provider groups to sign on to, asking for the administration and the legislature to talk about possible movement, either in a special session or at least when they get into session in 27. And hopefully before then, to address this, trying to circumvent the need for this 4% cut. I don't know whether it has a shot, as they say, an ice cube in hell or something. I don't know if it's better than that, but I'm going to hope so. So we will let you all know if that materializes. And I thank you all. And with that, we will adjourn. Thank you very much. And thank you for your assistance. Thank you to all the DMS folks and the MCOs for your participation. Bye-bye.
Bye.
Bye.